Last time we finished up on the Golgi tendon organs, and I thought just another picture to illustrate how this would be necessary to keep in check the agonist muscles. So remember, here we're talking about the biceps. Golgi tendon is mainly activated by contraction of the muscle. All right, and so we have this loop here that inhibits the agonist, activates the antagonist. And again, we do that all the time. If you're catching a ball, you're activating agonists and antagonists simultaneously. And for that very fine, for the ability of your upper motor neurons to precisely control movement, we need these kind of loops that they can manipulate. Right, so last time we talked about muscle spindles and Golgi tendon organs. And both of these provide the origin for the pathways we talked about last time that travel through the posterior columns. Remember, that's for proprioception, but also that form the spinocerebellar tracts. And here we can introduce a concept of unconscious and conscious proprioception. The muscle spindle Golgi tendon activation through the posterior columns is conscious proprioception. This is, I am now aware of where my finger is in space. That's a conscious proprioception. The information going to the cerebellum is sometimes called unconscious proprioception because the cerebellum needs that information about where your arms and legs are in space in order to act as a comparator to finally regulate movement, but you are not consciously aware of that information going through the cerebellum. These are circuits that happen automatically so that you can control movement, but you're not consciously aware of it. So just be familiar with those two terms. Before we get to the anatomy of the bladder, let's just say a bit more about the spinal cord. There's something called a flexion cross-extension reflex. This is really more important in terms of how it helps us to understand walking. But here, let's imagine you're going to step on a tack right here. Okay, so obviously that is painful, and so you're going to have this information going up through the spinothalamic tract, but that's not what we're showing here. You want to be able to withdraw your foot from that tack without needing the information to go all the way up to the brain, and then you can decide, oh, that hurts, I better move my foot. And so there is a loop here in the spinal cord. And just think about what needs to happen. You don't want to extend your leg when you're stepping into a tack, right? You want to flex and move the leg away from the tack. So what happens is the information goes in, and again, it's polysynaptic, and you are going to activate the flexors, in this case the hamstrings, and you're going to inhibit the extensors, like the quadriceps. And that allows the spinal cord to reflexively, because of the pain, withdraw the leg away from the painful stimuli. Okay, but if you're going to lift this leg up, you need to be able to immediately counterbalance on the other leg, or else you're going to fall. And so this information actually crosses over to do exactly the opposite in the other leg. Now we are going to activate the extensors, the quadriceps. We're going to inhibit the flexors, the hamstrings, so that you can balance on the opposite leg. All right, so that is the flexion crossed extension, okay, because the information is crossing over here to extend the other leg. But really what's more important is this is exactly what happens when you walk. We have this information here that is kind of going back and forth as you take one step on one leg and then on the other leg. These circuits in the spinal cord that are important for normal gait and balance. All right, one interneuron here in the spinal cord we'll talk about by name are called Renshaw cells. These are interneurons in the spinal cord. And this is another feedback loop. Okay, here's an anterior horn cell that is supplying the biceps muscle. And notice as it does that, it excites the Renshaw cell, which has a feedback loop right back on the anterior horn cell to inhibit it or to keep it in check. So the purpose here is so that, when you activate muscles, this is not just entirely, 100% yes or no. Things are kind of kept in check. And again, that is manipulated and controlled precisely by the upper motor neuron pathways. So these can regulate how active or relatively inactive the Renshaw cells are. It just allows for very precise movement. I bring up the Renshaw cells mainly because there is an important clinical application, a condition known as tetanus. Okay, now we haven't had our lecture on neurotransmitters yet, but there are two strongly inhibitory neurotransmitters, glycine, which is predominantly used in the spinal cord, and GABA, which is used up in the brain and in the brainstem. And glycine is the inhibitory neurotransmitter here that is used by the Renshaw cells. Well, tetanus, which you can get tetanus in several different ways, but often by a wound, stepping on a rusty nail, get bit by a certain type of animal, and so on. You'll go through all of this in our infectious disease lectures later on. But this actually prevents the release of glycine by these Renshaw cells in the spinal cord. What it actually does is it cleaves synaptobrevin, which is a snare protein, and the mechanism of that, we're going to explain how important these snare proteins are for normal release of neurotransmitters, but we will do that in the lecture on the neuromuscular junction. All right, but what I want you to really understand now is that in tetanus, we have a dramatic drop in glycine, an inhibitory neurotransmitter used by Renshaw cells. And so we lose that inhibition, and now the anterior horn cells are not kept in check, and so they're very overactive. And this leads to a lot of stiffness, spasticity, and so in the spinal cord, this makes the arms and legs stiff, and this can be very prominent here along the spine. This is known as opisthotonus, where the whole back can arch up. It's very rigid. Tetanus can also affect the inhibitory neurotransmitters in the brainstem. Here it's especially GABA. And this can cause very tight jaw muscles where the patient may not be able to open their mouth. That's known as trismus. Or rhizus sardonicus, which has the appearance almost like the patient is in a painful grimace or even a grin. And this is again from the very tight facial musculature. So these would all be signs of tetanus, which is certainly a neurologic emergency. Okay, and so several things here. We mentioned polio affecting the anterior horn cells. Tetanus, think of the Renshaw cells and the inhibitory neurotransmitter glycine. Okay, and botulism, we need to get all the way out here to the neuromuscular junction to explain that. So that'll come later. Now, whenever someone has a spinal cord injury, almost always there is a lot of bowel and bladder involvement. For men, having difficulty having an erection. And so for now, I'm just going to concentrate on the bladder. The innervation of the bladder is quite complex. This is a drawing that a fourth-year medical student completed for me recently, which is detailed, but it's really what you need to know to understand the innervation of the bladder. And the reason there's a real payoff to this is urinary incontinence is very common. And there's no way you're going to really understand the medications used to treat this unless you understand the neuroanatomy of the bladder. So let's go through this first in terms of storage of urine. Okay, so here we're just looking at kind of half of the bladder. Okay, so we have this filling with urine. Okay, and what happens here, we have these afferent pelvic nerve fibers that sense the stretch in the detrusor muscle. And so via the pelvic nerve, this comes in to the spinal cord, and it ascends up here to the intermediolateral cell column. Now remember, these are the preganglionic sympathetics. Okay, so you want to keep this straight. The sympathetics inhibit emptying the bladder. The parasympathetics activate, emptying the bladder. Remember, sympathetics are fight or flight. And during fight or flight, that's not the time to go to the bathroom. And so, this is, sympathetics are not going to be activated during that time. We want to inhibit them. And so, what needs to happen here is that to avoid voiding, we need to stimulate the intermediolateral cell column. Okay, we want to stimulate the sympathetics, right? It's not the time to void. And so this goes out through the inferior mesenteric ganglion, through the hypogastric nerve. And so we have norepinephrine on the detrusor via beta-3 receptors and on the internal urethral sphincter via alpha-1 receptors. And both of these act to avoid voiding. I'm trying to make a pun there, but so if we activate here norepinephrine on beta-3 receptors, that relaxes the detrusor. And the activation here actually ends up contracting the internal urethral sphincter. Okay, so this is preventing voiding here. This pathway continues up to the brain, and it goes up here to the paracentral lobule. So remember, we've talked about that as important for control of the bladder as well as the leg, but now we're interested in the bladder. Okay, from the paracentral lobule, this goes down to two areas in the pons that we haven't talked about yet. One is called the pontine micturition center. This needs to be activated when you decide to void. And we have the pontine storage center, which needs to be active when we're not wanting to void. So what the paracentral lobule does then, when it's not appropriate to go to the bathroom, it is going to inhibit the pontine micturition center, and it is going to activate the pontine storage center. Okay, so from the pontine storage center, this information goes down, and it further stimulates the sympathetics, intermediolateral cell column, to further relax the detrusor and contract the internal urethral sphincter. Okay, and then this information goes further down here to inhibit, you can see the little inhibitory mark there, the parasympathetics, which are down here in the sacral spinal cord. So we inhibit this, therefore we inhibit the pelvic nerve onto the muscarinic M3 receptors on the detrusor. If these were active, they contract the detrusor muscle. So we inhibit them to further relax the bladder. Okay, and the final step here is to stimulate these anterior horn cells here. These are called, have a name, Onuf's nucleus. And these travel out through the pudendal nerve. Okay, and when these are activated, this contracts the external urethral sphincter, and this is acetylcholine on nicotinic receptors. Okay, so all of that is going on continuously during urine storage. Stimulation of sympathetics, and again that happens directly and also as a secondary pathway from the paracentral lobule to stimulate the sympathetics, relax the detrusor, and inactivate the parasympathetics to further relax the detrusor. And then we have the action on the sphincters here to stimulate the external urethral sphincter via Onuf's nucleus and to stimulate the internal urethral sphincter here from the sympathetics. Okay, now when it's time to void, okay, we still are going to have this information. Now the bladder is really full, so we're getting a lot of information going on here, and obviously you can hold your bladder, right? And so everything that I showed you before will still be in place until, the appropriate time. But now let's just follow this information going up to the paracentral lobule. Okay, and when it is now appropriate to go to the bathroom, now we do exactly the opposite. We stimulate the pontine micturition center. We inhibit the pontine storage center. Okay, and so now this goes down to inhibit the sympathetics, which have the whole time been keeping in check the detrusor, contracting the internal urethral sphincter. Okay, and now we go down to activate the parasympathetics down here in the sacral cord. So via acetylcholine on muscarinic receptors, now we have contraction of the detrusor. Okay, and in parallel with that, you inhibit Onuf's nucleus here, and when that is inhibited, now we lose that contracture of the external urethral sphincter, which opens. Okay, so it's kind of an all or nothing thing with emptying the bladder. You all of a sudden switch from stimulating sympathetics to inhibiting sympathetics and activating parasympathetics. Okay, and we will, in our clinical lecture on the spinal cord, go over the clinical aspects of bladder difficulties and the medications that are used. Okay, I want to just finish up going over the different nuclei and pathways in the spinal cord that we talked about in the last lecture. And so I have both labeled and unlabeled. We'll go through the labeled sections, and then you should practice on the unlabeled and see how many you can identify. So here we're down in the sacral cord, and so in the posterior columns we only have fasciculus gracilis. Because remember, and this is arbitrary, really, but below T6 we call it fasciculus gracilis because that is for the leg. And once we get above T6, we begin to see some fasciculus cuneatus. So again, this would be vibration, proprioception. Here we see a dorsal root coming in. So again, for vibration proprioception, that's going to head right up like this. But for pain and temperature, it's going to come in and synapse here. And this, the white on all of these slides are nuclei. So very large nucleus here. This is the substantia gelatinosa. So this information synapses, it crosses over. Okay, this is the ventral white commissure, and it's going to travel out about in this location as the spinothalamic tract. Here we see it labeled over here on this side. Now, as pain and temperature information comes in, remember I mentioned that it usually ascends for a segment or two, and that is known as the Lissauer's tract. Okay, so we have a little bit of a, going up a few levels before synapsing on the substantia gelatinosa. Okay, the corticospinal tract is relatively small here, just because down in the lower sacral cord there aren't a lot of muscles, but we can see a little bit of it there. Okay, we're not going to see the dorsal spinocerebellar tract because remember that pathway hitchhikes up through the posterior columns until we get up to at least L2 or so. And so all we're going to see in terms of a spinocerebellar tract down at this level is the ventral spinocerebellar tract. Okay, so we have lots of anterior horn cells here in the ventral horn. Well, the sacral cord is small, and so this looks a little disproportionate. And then here we have our medial motor system here. All right, now this is about L2. And so these two pathways I mentioned that go from about T1 to L2, well, one is a nuclear column here. This is the intermediolateral cell column. This is just the lower part of it. This will be more obvious when we get into the thoracic cord. The other thing we see from T1 to L2 is Clark's nucleus, which is right here. Okay, so remember the information that will become the dorsal spinocerebellar tract first ascends in the posterior columns, then it synapses in Clark's nucleus, and then it moves out to the dorsal spinocerebellar tract, traveling up to the cerebellum. Okay, everything else is the same. So we still have down at L2, this is only going to be fasciculus gracilis. We can see Lissauer's tract, substantia gelatinosa. Here's the corticospinal tract out here, spinothalamic tract out in this location, and anterior horn cells, which at L2 are going to supply quadriceps muscle, the hip flexor like the iliacus. Okay, now we're at a thoracic level, and we know it's thoracic partly because very small group of anterior horn cells here, but notice we have a distinctive intermediolateral cell column, preganglionic sympathetics right here. And remember also, from T1 to L2, we have Clark's nucleus, okay, which relays out to the dorsal spinocerebellar tract, which I have labeled over here. Okay, so again, sensory information for pain and temperature, it's going to ascend a little bit in Lissauer's tract, synapse in the substantia gelatinosa, and then cross over in the ventral white commissure out to the spinothalamic tract, which I have labeled over here. Okay, so here in the thoracic cord, we're going to see both the dorsal and the ventral spinocerebellar tract, and we can still see the medial motor system here. All right, this is C8. So remember a large ventral horn here because you have a lot of hand muscles that all need neurons, axons supplying them. So big collection there of anterior horn cells. In the posterior column, now of course we're above T6, so we're going to have the fasciculus gracilis medially. So this is leg, vibration, proprioception, the fasciculus cuneatus laterally. Here we can see again a dorsal root, Lissauer's tract, substantia gelatinosa, ventral white commissure, and then the spinothalamic tract out here. Here's the corticospinal tract, or the lateral corticospinal tract. Then, of course, the rubrospinal tract is right adjacent to that. The dorsal and ventral spinocerebellar tracts, and again, our medial motor system. Vestibulospinal, tectospinal, reticulospinal, and the anterior corticospinal tract. We can see from the anterior horn cells the actual axon bundles here as they exit. So this is the ventral root and the dorsal root. And so remember the roots in terms of motor and sensory are far apart. Dorsal root here, the ventral root here. These come together eventually as the spinal nerve. All right, so I have a top 5 list of top 5 most often asked questions on a national board exam from this course. And this is definitely one of them. It's called the Brown-Cicard syndrome. And you can only figure this out if you know these pathways that we've talked about in the previous lecture. And so here we have the corticospinal tract, which crosses here at the junction between the medulla and the spinal cord as the pyramidal decussation. Okay, and then it's going to travel down to innervate anterior horn cells. So we know that if a patient has a stroke, anything that involves the brain or the brainstem, the weakness will be on the opposite side. Here we have in blue, the posterior columns. So remember, vibration, proprioception does not synapse. It goes right up the spinal cord. Synapses as the nucleus cuneatus, nucleus gracilis in the lower medulla. This kind of makes it look like it's spinal cord, but it's actually the lower medulla. It crosses over. Remember, these are called the internal arcuate fibers, and then becomes the medial lemniscus, which goes up to the postcentral gyrus. So notice if we have a lesion here, our vibration proprioception deficits will be on the same side, below the level of the lesion. Here is pain and temperature. Coming in, ascending a little bit in Lissauer's tract, synapsing in substantia gelatinosa, crossing over as the ventral white commissure, and then ascending as the spinothalamic tract, going up to the postcentral gyrus. Notice here, unlike these other 2 pathways, is that if we have a lesion of the left half of the spinal cord, the loss of pain and temperature is going to be on the opposite side of the body, below the level of the lesion. Okay, that's the key distinguishing feature. So if we have a spinal cord hemisection, and this can be from a disc pushing on the cord, one half of the cord, or maybe a stab wound that involves half of the cord. Okay, notice that below the level of the lesion, here affecting the corticospinal tract, we're going to have weakness, spasticity, hyperreflexia, clonus, Babinski, all of those upper motor neuron findings, they will be on the same side, ipsilateral. All right, the loss of vibration proprioception will be the same side as the lesion. Okay, so we'll have loss of vibration proprioception, same side. But the loss of pain and temperature will be in the opposite side of the body below the level of the lesion. And so what patients often will complain of with this is they'll say, you know what, my right leg is weak, but my left leg is numb. And so just sort of hearing that in the story would suggest, the lesion is, the weak leg is probably, the spinal cord on the same side is lesioned, and the crossing here, the opposite leg is numb from the spinothalamic tract. Okay, so Brown-Cicard syndrome is due to a spinal cord hemisection, and again, we get ipsilateral spastic weakness, ipsilateral loss of vibration proprioception, but we have contralateral loss of pain and temperature. So make sure you know this syndrome very well. All right, and then the last section here, I'll just point out, now we are very high cervical, like C1, C2, and you might think, well, this is thoracic cord, because look at the very small ventral horn. But actually at this very high level, there aren't that many muscles. This is mainly the spinal accessory nucleus here, which supplies the trapezius sternocleidomastoid, the upper part of the trapezius. So that's are not a lot of muscles. What's most unique about the very high cervical cord is that you have this pathway which seems to be pushing in to the gray matter. And this is actually the corticospinal tract. So why is it pushing in like this? Well, in our next lecture on the medulla, we will see that the corticospinal tract crosses in the medulla as the pyramidal decussation. And so those fibers cross in the midline, and then they move out laterally. And then eventually, of course, we see the corticospinal tract and all the rest of the lower sections of the spinal cord out here. It's moving out into that location. Okay, but everything else here at C2 is the same. We still have fasciculus gracilis, cuneatus, Lissauer's tract, substantia gelatinosa. So this is the only difference. Corticospinal tract is more medial here. Dorsal and ventral spinocerebellar tract, spinothalamic tract, and our medial motor system. And again, I do not care that you know exactly where the reticulospinal or the tectospinal tracts are. We'll just lump them all together here as the medial motor system.